Health Systems and Services Policy here at the Council of State Governments Justice Center. I'll briefly review the agenda for today's webinar and introduce our speakers in a moment, but first I'd like to take a couple of minutes to introduce the Justice Center. As many of you know, the Justice Center is a non-profit organization, national, that serves policymakers at the local, state, and federal levels from all branches of government. We strive to provide practical, nonpartisan advice and evidence-based, consensus-driven strategies to increase public safety and strengthen communities. The Justice Center provides technical assistance to the Justice and Mental Health Collaboration Project and Second Chance Act grantees, and we coordinate the National Reentry Resource Center funded by the Bureau of Justice Assistance at the U.S. Department of Justice. Established by the Second Chance Act, the National Reentry Resource Center provides education, training, and technical assistance to states, tribes, territories, local governments, service providers, nonprofit organizations, and correction institutions working on prisoner reentry. This online resource can be accessed at the URL shown here, and it includes publications, news updates, webinars, and other resources designed to promote effective reentry practices. And it includes the What Works in Reentry Clearinghouse, which is a database of evidence-based practices for reentry. We encourage you to visit the National Reentry Resource Center, where we've recently added new pages devoted to information and resources on health and health policy issues. We also encourage you to sign up for our newsletter by clicking the subscribe button in the top right-hand corner of our website. Today's presentations will be given by Ezra Ware of the Policy Research Associates, Cindy Schwartz of the Jail Diversion Expansion Program of the 11th Judicial Circuit Criminal Mental Health Project, and Etta Franco of the Center for Urban Community Services. Ezra will start things off with an overview of SSI and SSDI and Medicaid eligibility for individuals meeting disability criteria and the importance of these benefits for individuals re-entering the community after incarceration. She'll also discuss how the SSI, SSDI Outreach Access and Recovery Program, the acronym is SOAR, S-O-A-R, can provide opportunities to improve enrollment. Cindy and Etta will then follow with an overview of their respective organizations' efforts to screen individuals in justice settings with serious mental illnesses for eligibility for SSI, SSDI, and Medicaid benefits, and the enrollment successes that they've had to date. Lastly, we'll reserve time at the end of today's schedule for a question and answer session. To submit a question at any point during the webinar, please type your question into the Q&A panel at the bottom right-hand portion of your screen. We'll keep a running list of the content-related questions that we receive, and then ask the panelists to respond to the questions during the last segment of the webinar. We'll do our best to get through as many questions as possible. If you encounter technical or audio problems during the webinar, here are the numbers that you can contact. Today's webinar focuses on SSI, SSDI, and Medicaid disability enrollment for eligible justice-involved individuals. And I'd like to briefly provide everyone with an overview of the issue as we move forward. Each year, nearly 700,000 individuals are released from our state and federal prisons, and not millions more, about 9 million unique encounters cycle through our local jails. This population is affected by higher than average rates of disabling, serious mental illnesses, and most individuals currently lack access to health care and experience difficulty obtaining housing and employment upon reentry. In fact, one of the most serious barriers to successful reentry for the population is lack of access to income and other benefits such as health insurance. Enrolling individuals with serious mental illnesses and other disability and benefits and programs for which they are eligible can increase access to housing and treatment, and has been demonstrated to lower rates of relapse and is associated with increased time in the community. Many justice-involved individuals became newly eligible for Medicaid coverage based solely on their income on January 1st of this year, as part of the Affordable Care Act. However, we cannot forget about the housing and income challenges facing those who meet disability criteria and will continue to be eligible for SSI and SSDI disability benefits. Enrolling these individuals in programs that can provide income supports, cash benefits for housing, in addition to health care, can be the difference between their successful reentry in the community or a return to jail or prison. The federal SSI, SSDI Outreach Access and Recovery Training Program, which is a project of the Substance Abuse and Mental Health Services Administration, has been used effectively as a way to improve enrollment efforts and outcomes. As jurisdictions begin to focus on accessing Medicaid to improve inmate health and reentry outcomes, as well as to reduce state corrections health spending, there's no better time to turn attention towards the use of SOAR to achieve positive reentry outcomes for eligible individuals. Now I'd like to formally introduce our first presenter for this afternoon. Dazra D. Ware is a Senior Project Associate from Policy Research Associates for the SOAR TA Center. Prior to joining PRA, she served as State Georgia's SOAR Program Coordinator and State Team Lead at the Department of Behavioral Health and Developmental Disabilities. While there, she led a pilot program to implement SOAR in Georgia's state hospitals, jails, and prisons to promote successful transitions to community living. Under her leadership, the Georgia Department of Corrections employed multifunctional officers to assist offenders with Social Security disability applications prior to release. Her past work as a police officer, prison counselor, and program manager for individuals experiencing homelessness and mental illness helped shape her commitment to this issue. Without further delay, I'd like to turn this portion of the presentation over to Dazra.
Thank you so much. Hello, and thank you again to the Justice Center for the opportunity to join you on today's webinar. As mentioned, my name is Dazra Ware, and I am the Senior Project Associate for Policy Research Associates Incorporated. Policy Research is a nationally and internationally recognized leader in the technical assistance and research in behavioral health fields. PRA houses not only James Center, but also the Samson SOAR Technical Assistance Center, in which I work. As mentioned again, I have a background in criminal justice, corrections, homeless services, and recovery supports, and I have really been fortunate to work for this Technical Assistance Center since 2011, as it gives me the opportunity to kind of marry the two things that I really enjoy. The opportunity to integrate the experience that I've gained from my prior work in a way that enhances the likelihood of successful post-release for previously incarcerated people with serious mental illness and co-occurring disorders. Today's presentation will provide a brief overview of the SOAR model as it relates to justice-involved persons, an overview of the Social Security Administration's eligibility criteria, and the disability determination process with the key factors of the Affordable Care Act's impact on reentry. The SOAR Technical Assistance Center consists of a team of liaisons committed to the task of training individuals in the community on the SOAR model, providing support for communities and agencies with the implementation, as well as compiling national data on SOAR efforts around the country. The SOAR TA Center has developed an online course on the SOAR model that provides participants with an interactive, hands-on approach. The course provides participants with the opportunity to complete a Social Security application that is reviewed by the TA Center before receiving a certificate of completion. To begin, SOAR stands for SSI, SSDI, Outreach, Access, and Recovery. This model is funded by the Substance Abuse Mental Health Services Administration and supported through the Technical Assistance Center Policy Research Associates. The goal of the model is to develop Social Security applications for eligible individuals in a way that is comprehensive and complete so that the decision makers are provided with the information necessary to determine the case expeditiously. SOAR providers are trained in the Social Security process and to identify eligible candidates. The model encourages front-end preparation in order to avoid delays in the decision process. SOAR began in 2005 and has been initiated in all 50 states. Although there is no direct funding to states or communities, communities have found creative and innovative ways to fund their programs in order to include full-time dedicated SOAR providers. Later in the webinar, my fellow colleagues Cindy Schwartz and Etta Franco will discuss how SOAR was initiated in their organizations. The 2013 SOAR Outcomes include a little over 19,000 approvals upon initial application, resulting in a 65% approval rate overall, and this compares to the 10 to 15% for unassisted applications from people who are homeless and 29% of all applicants. Approvals were received in an average of 100 days in 2013. It's fair to mention that appeals take longer and people often give up on the effort. Of these outcomes, there are 4 states that have served more than 4,000 persons. Of those 4 states, they have an 89% approval rate on initial application. And these approval rates are highest in the places where the SOAR critical components are implemented. Of these states, the highest include Kansas, Maryland, North Carolina, Oregon, Pennsylvania, South Dakota, Tennessee, and Washington State. Any state that has not been included in this group can easily get there by more consistently applying the SOAR critical components and having stronger leadership at the local level. SOAR is more than the paper and the time that's invested in an application. It's about people. As stated in the previous slide, 19,008 people have been approved on initial application using the SOAR model. However, benefits acquisition is more than giving individuals a monetary reward. Although we can't minimize the positive impact that income can provide, the key is that the awards give way to resources that The key is that awards give way to resources that are not easily afforded to people without income. Particularly for justice-involved persons, the impact of obtaining housing is one of the greatest influences on a person's likelihood of returning to confinement. Without income, a previously incarcerated person is seen as a liability to potential housing partners. The financial influence gained from benefits acquisition can change a formerly incarcerated individual from a paying customer, thereby gaining access to housing, stable treatment, and the decrease of adverse outcomes, including recidivism. SOAR is designed to address the needs of individuals with serious mental illness or co-occurring disorders that are experiencing homelessness or at risk of homelessness regardless of their criminal history. Access to these resources, such as income, housing, and insurance, provide a firm foundation for successful reentry. The use of SOAR model with the pre-release applications prompts disability determination decisions prior to release. This allows the offender to begin receiving benefits and access to these resources upon their return to the community. SSI and SSDI are federal disability programs administered by SSA, or the Social Security Administration. SSI provides benefits to people that are low income, who are disabled, blind, or elderly. SSDI provides benefits to blind or disabled individuals who are insured based on their contributions paid to the Social Security Administration's trust fund according to their work contributions. Key health care programs available for individuals with disabilities include Medicaid and Medicare. Medicaid is associated with SSI, and it can be automatic in some states, and Medicare is associated with SSDI. For SSA to consider a person disabled, the person's impairment must affect their ability to work. Social Security defines disability as an inability to engage in any substantial gainful activity. Substantial gainful activity, or SGA, is defined by a monthly gross earning in the amount of $1,070 for 2014, and that's per month. because of a medically determinable physical health or mental health impairment that has lasted or is expected to last for a continuous period of 12 months or more or result in death, and the applicant must demonstrate the significant functional impairment related to this illness that impedes their ability to work. This slide represents a simple depiction of the application process. The application is filed at Social Security, and the determination is made for non-medical eligibility. Before the application can move on to the Disability Determination Services, or DDS, it must clear Social Security's non-medical review. Social Security then sends the medical information release to DDS, and DDS receives the application packet and reviews disability and functional information as it relates to work. DDS then makes the medical determination and sends a decision to SSA, and SSA notifies the applicant of that decision by letter. The sequential evaluation is a series of steps that are considered when making a final determination for disability. As discussed earlier, SSA makes the non-medical determination. The first step in the process is to ask, is that person working? If the individual is working and making an amount of gross monthly earnings equivalent to SGA, or that $1,070 a month, that person will be denied SSA at this step. If the applicant is not working or working below that 1070 and meets the non-medical criteria, the application moves on to DDS for consideration. In step 2, DDS asks, does the person have a severe impairment? They go back to the criteria that's set by Social Security and determines that the applicant has a medically determinable physical health or mental health impairment that lasts 12 months or more or could result in death and impedes their ability to function at work. In step 3, this is the first step that the person may be found disabled and begin receiving benefits. They look at, DDS looks to see if the impairment meets or is equal to the disability evaluation under Social Security rules, or it's also called the listing. And to be found disabled at this step, an applicant must include the applicant's medical evidence and the functional limitations that either match or is equivalent to a single illness or a combination of illnesses. DDS reviews the medical evidence submitted regarding the past and current treatments. If there is a lack of information to make the decision at this step, DDS continues on to steps 4 and 5, which are much more subjective. In step 4, DDS assesses the applicant's residual functional capacity, and DDS acknowledges that the person has an impairment, and then they ask, can the person still do relevant work despite this impairment? Relevant work is determined by deciding if the person can currently do any work done before. If the answer is yes, the application is denied. If the answer is no, the applicant moves on to step 5. Here the question is, does work exist for this person anywhere in the national economy? They do not consider whether or not the work is available. They don't consider whether the individual would be hired for the job. DDS will consider the age and education of the applicant and their past work history, and consult with the Dictionary of Occupational Titles, and they only have to find 3 jobs anywhere in the national economy for someone to do in order to be denied. So it's fair to point out on this slide, although hard to read, understand that there's only 2 opportunities for someone to be approved under Social Security, and SOAR focuses on the first opportunity at step 3. So step 3 is the key to SOAR success. The work of SOAR providers that collect the medical proof needed to be approved at this step is very important for applicants. It's the first opportunity for a person to be found disabled if adequate evidence is presented and that the impairment meets the listing, and the applicant is unable to work due to functional limitations associated with that impairment. SOAR works to get it right the first time. The next two slides focus on functional impairments that must be present when considering both physical health and mental health illnesses. For physical impairments, there is more emphasis on the physical demands of work, which may reduce the ability to do past work or any other work. With regard to mental impairments, the question posed by SSA still remains, does the illness hinder a person from working? Here, DDS requires individuals that have mental illness to provide not only diagnostic and durational information, but also evidence that illustrates the impairing effects of the person's day-to-day living. A mental illness diagnosis is not enough. DDS requires medical evidence, but this often is not included in the information, in the medical information about how the person functions, and definitely does not describe functional difficulties that impair the person's ability to work. SOAR providers must ensure that functional information is observed, collected, and reported to Social Security for all 4 areas that are required. Activities of daily living include self-care abilities, bathing, grooming, using public transportation. Social function includes focus on the applicant's ability to interact appropriately with others, concentration, persistence, and pace. Includes deficits in those areas that affect a person's ability to perform tasks commonly found in the workplace, and repeated episodes of decompensation. This area has to do with periods of increased or new symptoms that last for 2 weeks and have at least 3 episodes within a year. Episodes of incarceration, homelessness, and hospitalizations can be considered. Similar to the idea that a person cannot be found disabled based on illness alone, an individual does not simply qualify because they have an impairment in the functional area. They have to be related and SOAR encourages that the use of the medical summary report or the MSR to provide DDS with information that links the diagnosis to the functional limitations. In order to answer the question, why can't the applicant work? The MSR is the primary component in the SOAR model. So now that we have shared that brief overview, and I know it was quick, but it's important to understand what happens to benefits once the beneficiary becomes involved in the justice system. So the rules for SSI and SSDI beneficiaries who are incarcerated differ. Benefits for SSI recipients incarcerated for a full calendar month are suspended. But if the person is released within 12 months, SSA is reinstated upon release if proof of incarceration and release are submitted to the local Social Security field offices. There they review the individual's new living arrangement, and if deemed appropriate, SSI is reinstated. However, if SSI recipients are incarcerated for 12 months or more, the benefits are terminated and the individual has to apply again. Reapplication can be made 30 days prior to expected release date, but benefits cannot begin until actual physical release. Unfortunately, for people who are newly released, often wait months before their benefits are reinstated or even initiated. Few states and communities have developed legislation or policy to ensure prompt availability of benefits upon release, and consequently, a large amount of people with mental illness who are released each year are at increased risk of experiencing symptoms of mental illness, substance use, homelessness, and recidivism. For SSDI recipients, SSDI recipients are eligible to continue receiving benefits until actually convicted of the criminal offense and confined to an institution for more than 30 continuous days. At that time, SSDI benefits are suspended but will be reinstated the month following their proof of release. The Affordable Care Act, which was signed in March of 2010, provides an opportunity for people that are newly released to attain services and health benefits. These persons experiencing homelessness and those involved in the criminal justice system, particularly when they struggle with serious mental illness, are subpopulations that have been historically uninsured at high rates and have significant health care needs. The Affordable Care Act has now made it possible for this subpopulation to become eligible for Medicaid with access to these essential health care benefits. In fact, the influence of the Affordable Care Act for persons with disabilities that need to apply for benefits is very helpful for SOAR providers. Under ACA, there are basically 10 essential health benefits that must be included in all plans, and some of which include mental health and substance use disorder services, preventive and wellness service, hospitalizations, rehabilitation services, and lab results, all of which provide medical information that is really helpful and critical to the implementation of SOAR and the development of a complete application. As we know, Medicaid is a state-operated federal and state share the cost. It's in 32 states, and SSI's eligibility is typically equal to Medicaid eligibility. And for some states use the same eligibility rules as SSI but require separate application, and other states have additional criteria and eligibility rules. Enrollment in the Medicaid expansion is particularly important for people with disabilities. In addition to allowing access to needed medical services, the expansion also allows people with disabilities to attain physician signature and medical documentation that support SSI and SSDI applications. Medical documentation for disability is a critical component to getting an application approved. Once approved for SSI, beneficiaries may be eligible for traditional Medicaid benefits. People currently incarcerated are not eligible for Medicaid expansion, but people with a criminal history are eligible, as income is the only criteria upon which Medicaid expansion eligibility is based. So, in summary, SOAR works. It can be used as a tool to reentry services and works hand in hand with the goal to provide health care for many people as designed by ACA. Initial enrollment for justice-involved persons can give access to medical providers and the medical records and information needed in order to support the disability claim using the SOAR model. Access to additional medical records will provide SOAR workers with more medical evidence to support the disability claim. Once approved, the health care coverage package under disability may be more robust than the standard coverage. In acquiring SSA disability benefits and the accompanying Medicare benefits provides the foundation for reentry plans to succeed, and SOAR can be used as a tool for this success. This slide is provided so that you can have resources in order to contact the SOAR Technical Assistance Center. We welcome any questions that you may have. That's the end of this presentation. I'll hand it right back to you, Fred. Thank you.
Well, thank you, Desra. Now that we've heard a thorough overview of the benefits available to the SSI, SSDI, and Medicaid, we can turn to how these programs are used as an essential component of successful reentry. So we've asked Cindy Schwartz to talk about her organization's efforts using SOAR and the success that she's experienced in connecting these individuals to income supports and entitlements. Cindy Schwartz has developed and implemented programs and services for individuals that are disabled by severe mental illnesses. She currently serves as the project director of the 11th Judicial Circuit of the Florida Criminal Mental Health Project, its jail diversion program. In this capacity, she has worked towards decriminalizing mental illness by promoting system transformation, community integration, and recovery. Cindy has a master's degree in rehabilitation counseling from the State University of New York at Buffalo and a master's in business administration from Nova Southeastern University. In addition, she is a certified mental health first aid instructor, an advanced wellness recovery and action plan facilitator, and the lead trainer for the SOAR project in Miami-Dade and Monroe Counties, Florida. Cindy, I'll turn this over to you now.
Thank you, Fred, and thank you to the Justice Center for allowing me to talk about our program that has been so successful. And also thank you to DASRA and to PRA for helping to promote SOAR across the country. DASRA did a great job this afternoon telling us about what SOAR was all about, and I'm going to talk to you about how we use the SOAR model to facilitate reentry from jail. So before I even begin, I'd like to tell you about our jail diversion programs. Our programs were designed and implemented to divert people with serious mental illnesses away from the criminal justice system and into community-based treatment and services. We have a pre-booking CIT program. We have trained approximately 4,000 police officers in Miami-Dade County, and we have really been able to recognize the change in values from the police and also from consumers towards police, and this has made a huge difference in our community. We have post-booking programs, we have a misdemeanor program and a felony program, and we also have an entitlement unit, which I'll be talking to you about today. Our program also helps to develop a forensic diversion project, and all of these projects work together. We try to link people to treatment and services in the community so that they can move towards successful community integration and recovery. We have funds from the state for housing, treatment, medication, and ancillary services so that we can help to provide immediate linkages upon reentry to the community. So what's the problem? What we've experienced is that the application process for Social Security is difficult for most people, but it's especially difficult for people who have mental illnesses and co-occurring substance use disorders that are re-entering the community from jail. As DASRA said, I think DASRA said that only 29% of all applications are approved on the initial application. So we know that it's very difficult to get approved for Social Security. People that are homeless have lower percentage of approval on the initial application, and that's only 10 to 15%. And DASRA also said that appeals take years, and many potentially eligible people give up and do not appeal at all. We know that meeting basic needs are what people need to move towards recovery. And without a roof over your head and access to health care and some money in your pocket, people that are re-entering the community from jail will face the revolving door of homelessness and incarceration. There's a catch-22 here because if you can't access health care because you don't have health insurance, you won't be able to document your disability or the duration of your illness. So we have seen that people that are reentering the community need help to apply for Social Security benefits. They need an adequate assessment and they need documentation of how their disabling conditions limit their ability to work. This is just not based on disability alone. You must be able to document the disabling conditions that limit the ability to work. And providers need to assist applicants and train staff who understand the disability determination process and have the time to assist in all aspects of developing the application. It's very important to develop relationships with the Social Security Administration, the State Disability Determination Service, community medical providers, and others that are essential to changing the outcomes of the disability process. So, in our program, we developed an innovative plan. When I first heard about SOAR, I said, this is going to be great, not only for the people that we serve, but for our program as well. We're going to be able to help people to re-enter the community and move towards recovery, and we hope to maximize the limited funding that we had from the state. So we decided to use the SOAR approach. The first thing that we do is screen everybody for eligibility for entitlement benefits. Those applicants that are eligible are provided with assistance with the Social Security process, and this also allowed us to market our program to treatment providers because we were giving them an incentive. We said that if we would do the application for Social Security, that they could potentially maximize their own resources and recoup unfunded days in the hospital and in community centers. Again, we know that providing benefits will help a person to move towards community reentry, self-sufficiency, help them to access their basic needs such as housing, food, medical care, psychiatric treatment and services, and also, very importantly, it helps to reduce stigma. We are changing these people that are reentering the community from poor, disabled, criminals into attractive paying customers. So we started our program in the year 2008, and we worked through 2011. And we determined over those 3 years that although SOAR was working very well, our court case management specialists had many difficulties in terms of time and getting information to do the job as well as they would have liked. The court case management specialists were also trying to help people to link to community-based treatment and service upon reentry, and the SOAR process takes time if you really want to do it right. So we decided to create a specialized unit to expedite access to benefits. And we applied for a state of Florida Reinvestment grant to do this. Through this grant, we expanded the target population to include individuals reentering the community after the completion of their jail sentence. And then we also included other people in the criminal justice system that were identified with mental health challenges from the public defender's office or the state attorney's office or wherever they were in the system. This grant also helped to provide a component in regards to program evaluation to assess the efficiency of accessing benefits and the effectiveness of jail diversion and reentry planning. So as a part of this grant, we hired 3 full-time staff, and these staff are charged with engaging these people that are reentering the community from jail, They are also charged with doing an in-depth assessment that will look at how disability impacts functional limitations to work. These staff also have to be boundary spanners. They have to be able to collect information from across many different systems. They may have to collect medical information from the jail and the correctional health services. They may need to go to other health services in the community. They really have to be boundary spanners and sometimes even act as private investigators to put the pieces of the puzzle together. We also have 2 part-time peer specialists that provide support, and they also provide assistance with access to community services. So if we have people that are fragile and are having difficulty accessing appointments so that we can get all the information we need, our peer specialists will be supportive and will help them to get to these appointments. This is the people that we serve. We have come to recognize that we have about 19% are female, 81% are male. The average age is about 36 years old. 57% of the people that we serve in our benefits entitlement unit are homeless. The average time of homelessness is 22.2 months. 34% are at risk of homelessness, and only 8% are housed stably in the community. Now, this is an interesting look at our diagnostic criteria. 22% have bipolar disorder, 14% have a depressive and mood disorder, and the overwhelming majority of 60.5% have some type of psychosis or schizophrenia. So, we've done pretty well, and I must tell you that I'm very, very proud of this program. We've screened 445 people, and the dates of the decision were from 7/11 to up until the last week in February. We've screened 445 people. We've made a total of 220 applications. 207 were approved, 13 were denied, and that gives us an approval rating of 94%. Also very importantly, our time to decision is 27 days. So we are helping people to move towards community reentry and recovery in a very quick amount of time. This helps us to not only serve the people that need the benefits the most, but also to maximize our very limited state funding for housing, medication, and treatment. So 94% of the people that we serve are approved for SSI, 1% is approved for SSDI, and 5% is approved for both. Now, the financial benefits of our program are obvious. Our approval rates far exceed the national average in 1/10 of the time to decision. We do maximize the use of our state funding, which means that we can now serve more people in our jail diversion program. This leverages the equivalent of more than $33,500 annually for each individual served in state-funded treatment. And it helps us to access approximately $5.9 million annually in state-funded equivalent services. Now, this is an interesting finding as well. Our evaluators looked at the number of jail bookings, and they looked at them and they were able to document that the number of jail bookings after the approval of benefits was statistically significantly lower than the 1- and 2-year period before the approval of benefits. Now, this finding does not indicate that the SOAR program alone was responsible, because we know we've also helped our people to access treatment and services in the community and housing. So we know that SOAR leads to a faster approval of benefits for individuals who historically do not have many resources. Therefore, by being approved for benefits, it's easier for them to afford medical and mental health care, housing, and other basic needs. It's possible that these resources are resulting in a lower number of bookings, but based on the available data that we have, this relationship has not been explored at this time. So I wanted to give you a couple of success stories that we've had with people, just to give you a basic picture of the people that we're serving. We had a 22-year-old homeless black male that was diagnosed with schizophrenia, chronic paranoid type. He was homeless since the age of 14. He had a long history of arrests in Texas and in Florida. And once he came into our jail diversion program, we were able to successfully engage him in housing, treatment, and supportive services. When we applied for his Social Security benefits, he was approved in 18 days. That's some pretty wild success, don't you think? And here's another success story. A 21-year-old black male diagnosed with schizophrenia, chronic paranoid type. He was charged with petty theft and battery. He had 8 hospitalizations in 1 year due to the psychiatric illness and lack of treatment. He was successfully engaged in treatment and services by our jail diversion program, and it took us 21 days to get him approval of SSI. So what I really want you to know today is that focusing on expediting benefit works. This has been very successful for our project, and we have seen people move towards community integration and recovery once we can help them to meet their basic needs like housing, health care, and just having a couple of bucks in your pocket, so that they're like anyone else that is living in our community. It's a win-win for the individual, for states and localities, and for community programs. And it is a major tool in community reentry and recovery. Thank you very much.
Thank you, Cindy. It's interesting to hear, and I'm seeing questions already about the challenge of doing this work in a churning environment like a jail setting, where people are released quickly and sometimes without a lot of warning, and we'll get back to that during our Q&A session. Until then, and I would like now to introduce our next speaker, Etta Franco, who will discuss the efforts of her organization, the Center for Urban Community Services, or CUCS, to facilitate reentry for individuals who are leaving the prisons in New York State. Etta Franco is an Associate Director at the Center for Urban Community Services, an agency that matches Etta's commitment for helping others and making a difference in the lives of the disenfranchised. With a mission to end homelessness, CUCS is a nationally recognized organization for its innovative work with special populations. Etta received a BA in psychology from SUNY Old Westbury and holds master's degrees in social work from Hunter College and an executive MBA from Pace University. She's a licensed social worker and has dedicated the past 24 years working in the fields of chemical dependency and mental health. I'll turn this over to you, Anna.
Thank you, Fred, and thank you to the Justice Center for the invitation to discuss the work that we're doing here at CUCS. It's indeed a pleasure to be here with you to importantly speak about our SOAR experience. But first I would like to speak about a little bit about CUCS. CUCS is a nonprofit agency that provides social services for low-income and disadvantaged New Yorkers. Our primary focus is comprehensive mental health, substance abuse, and social services for people with serious mental illness. Particularly, our entitlements work is done through our Reentry coordination system, which serves to connect SMI individuals releasing from New York State prisons to New York City to care coordination, outpatient mental health treatment, as well as housing and entitlement. We feel that these are the cornerstones that are necessary for successful reintegration into the community. We are also fortunate to have government partners that support the work that we do with justice-involved individuals. And the Office of Mental Health for us is our partner, and we're always thankful for their support and commitment in the work that we do. With that said, today my goal is going to be to talk to you about how we utilize the SOAR model in our work at the Simpson Correctional Facility Core Unit, also known as the Community Orientation Reentry Program, and the State Transition Empowerment Program, also known as STEP, located in the Bedford Hills Correctional Facility. In 2005, our work began at the Core Unit, and the Core Unit, just so that you know a little bit about it, is a specialized program that offers serious mentally ill inmates structured support and services as they prepare to re-enter the community. Inmates that meet the criteria for CORP are sent to the unit at least 90 days before they're set to be discharged to the community. The CORE unit provides this program to all eligible individuals that have SMI located in New York State facilities. In the CORE unit, the entitlement liaison is largely responsible, and this is the person that handles the day-to-day work there at the facility. And their primary job is to complete SSI and SSD applications, Medicaid applications, as well as the medication grant program. And this is also known as MGP. The MGP allows clients that are discharged from prison to have access to medication coverage through Medicaid should they need it. Additionally, the entitlement specialist also offers housing options training, and this is helpful because it gives the inmates an opportunity to learn about the different type of mental health supportive housing that's available to them and what they may qualify for. In 2011, we expanded to Bedford Hills Correctional Facility. And aside from doing the same work that is completed at the CORE unit, at Bedford Hills, we also complete what's called HRA 2010E, which is the New York City Mental Health Supportive Housing Determination. Our local Human Resource Administration is responsible for making that determination of what eligibility a client may qualify for, dependent on the documentation that they received, and I will talk a little bit more about that later. Additionally, at Bedford, those services are given to all the clients that are SMI and are in the facility. The last component for us is training and technical assistance to the pre-release coordinators in New York State. Some of the trainings that we offer them are effective documentation, housing options. We've even provided SOAR training to the Albion Correctional Facility. Additionally, trainings are offered through the Academy for Justice Informed Practice, also sponsored by the Office of Mental Health. Now I want us to take a look at some of the numbers related to the work that we're completing at CORE. Now, Cindy, I'm excited about what you just presented about what's happening in Miami-Dade, and I think that I would like to talk to you further to get some insight about that so we can improve our numbers as well. But I think we're doing pretty good in terms of the work that we're doing here. The work at CORE, as I stated already, was initiated in 2005. And since that time, we've worked with 376 discrete individuals with serious mental illness and a total of 404 applications. In that group of folks, we've had 70% that have psychotic disorder, 41% that have antisocial personality disorder, 30% with affective disorder, 6% with borderline personality disorder, and 1% with PTSD. And 94% have co-occurring substance abuse disorder. And it's important in this work that we have a clear picture of the inmate diagnosis and the day-to-day function, and to help ensure that the application reflects really a true picture of what the client need is, because that's what they base it on. That's what HRA bases it on, as well as SSA office when they do reviews. For the core unit, we have an 86 approval rating at this time. Also, we advocated for the SOAR model in order to conduct intense chart reviews for information that would strengthen the housing application. Because as I stated already, the reviewers in both SSA and HRA can only make a determination based on what's written. And so the stronger you write on the application to reflect the current functioning, to paint a picture of what is the true reflection of how the clients interacted and while they were in prison, also clarifying any issues that might be vague or not clear in the history is also helpful in successfully achieving approval rates. It's also important to involve the inmate in the process, and any time that we review cases and something is not clear, although we are not the direct contact with the inmate, we coordinate with the pre-release coordinators to ascertain the additional information that we may need in order to improve or strengthen the application. Another reason why it's also helpful is in the groups that we offer, it allows the pre-release coordinators as well and the pre-release staff and inmates to ask questions about the process. You know, a lot of times clients just need to know the information. They're not really clear on what services or what's available to them, and it's a source of helping them to understand that this is part of their reintegration, and we're glad that we have this offering for them to allow them to move forward. Now, when we look at Bedford Hills, which initiated in July 2011, we worked with 133 discrete individuals and a total of 158 applications. Some of the demographics for Bedford Hills are as follows. 52% have psychotic disorder, 36% affective disorder, 17% personality disorder, 10% PTSD, 8% antisocial personality disorder, and a total of 95% have co-occurring substance abuse disorder as well. At Bedford Hills, we also utilize the SOAR model to review charts in the same way that we do at CORP. We understand that the use of the SOAR model improves clinical documentation and produces good outcomes. Although the approval rating at Bedford Hills dropped significantly last year, one of the factors is that the documentation that is written is showing that SMI individuals are fit for work. This highlights the point about the importance of demonstrating the individual's functional impairments in conjunction with their diagnosis within the documentation. And so you have to be able to indicate through the writing that this person is in need of the SSI benefit. If they feel that if that is not strengthened, if it's not strong enough, then it reduces approval rating. And because we're always in a process of improving and looking how to do things, we implemented a new review process with the Office of Mental Health to help address these issues. And so when we have applications that we may feel that may not get through the process, we review it with the PRC supervisor to get feedback and to see if there's anything that may be missing or information that may not have been included in the original application to strengthen the case for the approval of the case. Additionally, I want to speak about that I'm sure you noticed the average time for determination is greater in CORE than in Bedford-Hill. And actually, Bedford-Hill is the beneficiary of the relationship developed within the SSA office and the entitlement liaison. And what I mean by that is that Bedford-Hill benefited from the lessons that we learned while starting the CORE unit. Initially, when we started CORE, we didn't have a designated person at the SSA office. There wasn't that information and there wasn't that exchange to see, how we can work things, how can we handle the cases. But once that we were able to develop those relationships, if you look at the same time period, so let's say we look at CORE from July 2011 and Bedford from 2011, there's little difference in the wait time, and CORE actually average time from that period to now is 55 days, and Bedford is at 54 days. So it also highlights the importance of looking at the system, how the things that you're doing, are they effective, or how can you make it better? And then develop the relationship with your SSA official to be able to address the needs of the client and to meet and to get the approval, because ultimately that's the goal. The goal is to have the client connected to these services before they leave the facility as often as possible. Okay. So for lessons learned, I want to talk a little bit about, and this is where I want to spend the bulk of time, because that's really what I want you to take away today is, this is an ongoing work for us, and we're looking at the process with our partners at OMH to see how we can do things better to improve our outcomes in attempting to achieve approval. So one of the first things is avoid broad statements, and I know I'm guilty of that. I'm a social worker, and we like to say things like poor insight. And so what does that mean? What does it mean? What does it look like for a client that has poor insight, and to give that level of detail? And also, how does it affect their ability to work? You have to draw a picture. It's almost like you're designing a picture. Like if the person, the reviewer that's reading it, whether it's at the SSA office or the HRA office that's making a determination, they need, when they're reading the clinical documentation, they need to have a sense that this is the story of the person. It's almost as though the person is sitting in front of them, and make the connection between the need and what the client is showing. Other things important to include is the history and housing. How were they before? How did they engage before in the community? These things are important for us to talk about and to include. Another piece is to have a designee at the local SSA office. That we found that you saw it dramatically drop our wait time in terms of determination by having a person that we could contact to ask questions about applications, get clarity, if going through the appeal process if we needed to, or whatever it is, that we were able to access that through having that relationship with a local representative of the SSA office. And they want to help, they want to participate in the process, and so the more they know about the folks that you're working with, and you connect, name to name, it makes a difference in the work that we do. Another point which I highlighted earlier was about being clear about the client's diagnosis, their day-to-day functioning, highlighting functional impairment. You have to show that picture that this person needs SSI because you can see that they can't manage day-to-day activities, or they're not engaged, or whatever it is that they're presenting to you, that you're able to write that clearly for the person that's reviewing the documentation. Another piece is that good supporting documentation should be organized, thorough, and balanced reflection of the applicant. You want to give a true picture. If there's, and I know we have clients that have challenging histories, and they have things in their history that might, be hard to explain, but you have to explain those things as clearly as you can, and not leave anything up to the imagination, because a lot of times people misconstrue or it affects them because they are not clear about how to respond. And so if, let's say, for example, you're dealing with someone that's a fire setter, it's important to include information about that and how is that affecting their functioning when you're dealing with housing, for example. The provider wants to know, when was the last time and what's the likelihood that they're going to do it. It doesn't do any good to skirt around any issues that are in their history. And it all goes together in working in conjunction with the client to get that level of detail that you need so that it can be clear. And the picture that you're seeing every day, you're really the person that's completing the application. You have the most current view of the client. And your input about what you're seeing day to day. How are they doing in the facility? How are they connecting, with their responsibility is important to make sure that you have those things together so that the application can be, as thorough and organized as possible. And another piece is also the applicant. I talked about that earlier about it being one of the cornerstones that we feel that's important. Care coordination and ACT services for us is assertive community treatment. It's critical that a client is connected to these things once they leave to help support their reintegration into the community and to help them work through whatever issues or whatever challenges, because let's just say for some reason the application is not we don't receive a determination by the time that they leave. They're going to need help in the community to help them follow up with their local office. And believe it or not, a lot of the clients may be released to New York. They're not familiar with the system, and so when you have a care coordination team that's waiting for them to help them navigate to get to the office and handle whatever they need to respond to get the application approved, that's always helpful to clients, that they need that level of support to make sure that they are connected to services. Another piece is that you have to remember about writing things that are set off red flags for providers. And you got to give things in the context in which they happen. It's important that you are able to define and clarify any issues and any things that are not clear in the process for them so that the provider that's going to continue to work with them and the client are able to deal with things once that they leave out the facility. We really try to get most of the clients connected as much as possible before they leave the facility, but sometimes is not a possibility. So again, the connection with aftercare providers is critical before the client leaves. So with that, I would just like to introduce Anika Velez, who has oversight of this forensic program in our unit, and also Wendy Vogel from the Office of Mental Health, both who will be available for the question and answer. So I thank you for your time and the opportunity to present today.
Well, thank you very much, Etta. Appreciate it, and all of our presenters. A lot of information, and we have a lot of questions and a little bit of time. So I'm going to do my best to kind of group some of the questions as possible and not direct it to any one particular person at this point. A couple questions have come in about how do you assess functional impairment in a correctional setting, and is there a consistent standard for making that assessment? I'm going to pair that with a second question, which was asking, is the fact that a person is incarcerated for an extended time frame make the Medicaid approval any easier? Doesn't incarceration validate not being able to work? So the whole notion of how you get the information for individuals that are in incarcerated settings.
I can take that question on.
Please.
Hey, this is Gazara from the SOAR Technical Assistance Center. Oftentimes people really, really struggle with this question. They think that simply because someone is in a controlled environment that it makes it less, more challenging to kind of point those limitations in functioning out. And even though someone is kind of in a controlled environment, the challenges associated with severe mental illness or other impairments can be seen, but they just have to be looked at kind of differently. In the community, if someone is struggling with social functioning, they might get in fights and they might have an inability to bathe themselves or things like that. And in a controlled environment, they may have to take a bath, or face punitive consequences. So I encourage people that are working with justice-involved individuals to look at the people that have their hands on that individual. Talk to other staff, talk to correctional officers, talk to their social workers or their case managers. Find out who they are, what kind of supports that they have within the institution. Is there a bunkmate or a cellmate that is constantly reminding them to take their medication or constantly reminding them to take a bath? Or, do they get in fights in the prison? Look at those areas that we won't even we might not consider at first. Oftentimes, in the community, people with limitations in functioning are subject to arrest. So we can see that, there's a history because of their arrest, because of fights and so on and so forth. In a institutional setting, those same consequences look like disciplinary reports. So if you have someone that has an extensive history of disciplinary reports and incarcerated, look a little deeper at those incidents and find out what's behind them. The greatest example I can give you is working with an individual who constantly got disciplinary reports, and when I looked further into it, it had something to do with a loud detail. Every single time she was assigned a loud detail, she would get in fights and cause a disturbance and get a disciplinary report. And just like Etta stated, sometimes you have to look a little bit deeper to find out the full history of the individual in order to paint the picture for DDS, who never gets to see this individual. So when I looked further into these disciplinary reports, I found out that this woman had a really kind of horrific childhood that resulted in tons of trauma that led way to me investigating a possible head injury. And through engaging with her and talking to her and looking deeper into those disciplinary reports, I found out that she did indeed have a serious head trauma or a serious traumatic brain injury that resulted from that trauma. So although they are in a controlled environment, there's different ways to look at that, and I encourage anyone with that question to kind of reach out to me, and I'll give further information on it. I don't want to eat up too much of the time.
And this is Cindy. I would just like to add that when you look at the Social Security listings, it's like a recipe. If you have a diagnosis, if you have a psychosis, schizophrenia diagnosis, the listing will tell you exactly what you need to have in terms of functional limitations. And the functional limitations are broken down into activities of daily living, social functioning, cognitive skills, and decompensation. So you look at those listings and you work it like a recipe, and you select just what you need, and you then go to the behaviors that demonstrate that there are limitations in those areas. And when you put it together like that, you have a format, a formula to follow that you can find the behaviors that will indicate that there are limitations, and then sometimes you have to make a leap to say, as a result of these functional limitations, they would not be able to work. Let's say in the area of social functioning, they have difficulties with authority. You would say that person would not be able to get along with a boss. You see where we're going with that? You put the pieces together.
You have to, that's absolutely right, and thank you for that, Cindy. And to kind of, tie it all together, it has to be more than a medical diagnosis. You have to be able to tie that medical diagnosis to someone's inability to function, and you have to find those functional limitations even though someone's incarcerated. And there's different ways to look at those, but you have to talk to people. Oftentimes it relies on collateral information from more than just the caseworker or the social worker that talks to this individual. Thank you, Cindy.
Thank you. Thank you. Let me throw out a couple questions that have come up around the differences in applying under the newly eligible criteria in expansion states, Medicaid based on income, for individuals that might also be eligible based on disability criteria. And is there any advantage to applying under one eligibility standard versus the other? Can both the applications be completed simultaneously? And are there differences in the coverage and services that those two programs might afford?
Okay, I'll take on some of that. For the purposes of applying for disability, it would be beneficial to the applicant to apply for Medicaid enrollment at the earliest possible time. That will allow the individual to gain access to all the health services and all the medical records that are collected from those health services in order to substantiate a Social Security disability application. So oftentimes we are really, really faced with the challenge of people that have very sporadic health histories, very health histories with huge gaps in them because they don't get to see a regular doctor and they use medical emergency rooms as their source of primary care. So with the implementation of ACA, they will be able to have medical coverage that provides the same doctor and have more consistent medical records that will be used to substantiate fully Social Security application. So we encourage that they apply at the earliest possible time. Now, those records can be used to substantiate, once again, the Social Security application. And if the individual is approved based on that medical record, those medical records that they get, then it's unclear how the differences would look at this time, but I imagine that Medicaid under the disability would be a little more robust than the other coverage or the initial coverage, but it's still not clear at this time. And I know that there was one more part to your question, but I can't remember what it was.
It was as if there are if you can apply for both at the same time. That is, on the basis of income level for the newly eligible, defined by ACA, and for the categorical categories related to the mental illness disability.
Yes, I'm sure that you can apply for this at the same time, simply because to get an approval for the disability would take a little bit longer. So I'm sure that you could apply for the same time, receive coverage for the initial health coverage, and then have that health coverage transferred to the disability insurance once that decision comes in.
Great. Thank you. Several questions have been related to the high approval rates. And Cindy, I think I'll direct this your way. The questions relate to is it simply a matter of understanding the process and having knowledgeable staff? Another question was, how do you screen? Because there was a group of individuals that you looked at who you didn't move forward with in the SOAR methodology. So what are the ingredients that contribute to those high rates?
Okay. Well, the first step of the process is screening. And our entitlement specialists are very familiar with the Social Security process. So they know exactly what the eligibility criteria is. So they are looking for people that have medical documentation, a confirmed diagnosis. We work very closely with our drug court and our mental health courts. Sometimes we get referrals from our drug courts for people that have substance use issues. Now, we know that Social Security does not allow for substance abuse in their listing. So if the primary diagnosis is substance use, those types of people may be ruled out if they also don't have a primary diagnosis of a mental health issue or a physical issue or something that is in the listings for Social Security. So screening is a very big part of it. Also, in Miami-Dade County, we have many people that are undocumented immigrants. And we will work with undocumented immigrants to help to resolve their immigration status. So those people may be working in a whole different track before we can help them apply for Social Security benefits. You have to resolve the immigration status. So the answer to the question is our screening is very, very important, but it's equally important that our entitlement specialists know the eligibility requirements, know what the process is, and then they do some upfront investigative work to make sure that we will have all of the documentation we need to hit the ground running. They'll make sure that the person, if the person is being released from jail, that the person is linked to a treatment provider immediately upon release so that we can begin to work with that treatment provider and get all the documentation that we may need, including a current psychiatric evaluation, list of medication, whatever it is. Our entitlement specialists will act as boundary spanners. I saw that there is a question online, what is a boundary spanner? And a boundary spanner is somebody that can work across multiple systems. So they may have to go into the jail and get corrections health services to provide documentation about what they were like while they were in jail, what medications they took. They may have to go to a current treatment provider to make sure that the person's engaged in treatment and taking medication, seeing the psychiatrist. And then they may have to also span the boundaries with families and anybody that can give information that will help to get that approval. So our entitlement specialists do whatever is necessary to collect information and also to engage the client so that we can have a successful outcome.
Terrific. So many questions and so little time. I think we are in a position that we will need to conclude today's webinar. I want to thank all of you for participating, taking time out of your days to join us here. I want to extend special thank yous to Desra, Cindy, and Etta for their presentations, which were quite informative and illustrative of both the challenges but also the successes that can come from the application of SOAR and a concerted effort to link people to the income supports and entitlements that they are eligible for. After you exit the webinar, a brief survey is going to appear on the screen. By answering the questions in the survey, you'll be helping us at the Resource Center, at Justice Center, improve on the services we offer, and we'd greatly appreciate it if you would take a few minutes to complete the survey at the end of this webinar. While we can't applaud in any way that could be heard, I want to start with my own applause on this end and bring this webinar to a close. Thank you all for your participation.